Good morning, colleagues. Thank you very much for joining us for this PANCAP PAHO webinar. I am Dr. Shanti Singh Anthony, the Knowledge Management Coordinator for the Pan-Caribbean Partnership Against HIV and AIDS. And I am your moderator for today's webinar on promoting sexual health and wellness in primary care. Again, this is a PANCAP webinar in collaboration with the Pan American Health Organization. A few housekeeping notes before we proceed. Your mics are muted, so if you have any question as the presentation progresses, please type and submit these. You would have on your webinar panel a chat bar. You can type and submit your questions there. We'll take your questions during the question and answer segment that is scheduled after the presentation. Secondly, we're recording the webinar. The recording will be shared on PANCAP social media platforms for the benefit of other members of the partnership who could not have attended this live session this morning. By continuing to be in this webinar, you're consenting to be recorded. This is important. At the end of the session, you will receive a certificate of participation. And finally, you will also receive a post-webinar evaluation. I'm kindly encouraging you to complete the post-webinar evaluation because your feedback is important to us as we continually strive to improve your webinar experience. This morning, like I said, the webinar is on promoting sexual health and wellness in primary health care, and we have for you presenting this morning is Dr. Keosha Bond. She is an assistant medical professor in the Department of Community Health and Social Medicine at the CUNY School of Medicine. Before I go further into the introduction of Dr. Bond, we have a few poll questions and I'd like to launch these now. So if you can, please work with us. Submit your answers. These are very straightforward questions. They're multiple choice. And so very quickly in the first minute, we're collecting responses for the first poll question. Thank you very much. Please continue to submit your answers. We're doing good. Okay, I can see that some of our attendees are still submitting their responses. 30 seconds and I'll close this specific poll and move on to the second question. All right, thank you, colleagues. I'll close this poll, this question, and I'll move on to the second. All right, second question is up. Okay, I can see that the responses are still coming in. I will allow an additional 30 seconds for this question. All right, thank you very much, colleagues. I'll close this second question and I'll move to the third question. The third question is up at this point. Please go ahead. Okay, thank you very much, colleagues, for submitting your responses. We will take the presentation at this point, and we will review the responses with you, with the presenter at the end of today's session. So I'll close this poll right now, and we will move into the presentation. So, like I said, our presenter for this morning session is Dr. Keosha Bond. She is an assistant medical professor in the Department of Community Health and Social Medicine at the CUNY School of Medicine and is the director of the Love Project Lab. Dr. Bond is a certified health education specialist. She holds a Doctor of Public Education from Columbia University Teachers College, a Master's of Public Health from CUNY Hunter College, and a Bachelor's of Science in Psychology from Fordham University. She also completed an NIDA-funded postdoctoral fellowship in drug abuse research at New York University Rory Myers College of Nursing. She is a visiting faculty fellow at Yale University School of Public Health Center for Interdisciplinary Research on AIDS, an affiliated investigator at the NYU Center for Drug Use and HIV, Hepatitis C virus research, and a diversity scholar for the Adolescents Medicine Trial Network for HIV/AIDS Interventions. She sits on the board for the American Sexual Health Association and New York City Therapeutic Community Incorporated. It gives me great pleasure, therefore, to invite Dr. Bond to present to you this morning on sexual health and well-being in primary health care. Over to you, Dr. Bond.
Hello, good morning, everyone, and thank you again for that lovely introduction. I am happy to be here to speak to everyone about promoting sexual wellness and health in primary care. Uh, and one of the things that why this is so essential is that usually in sexual health we tend to forget about sex and we forget about the different aspects in people's lives that may influence their sexual health outcomes. So for today, in our overview of this lecture, we're going to discuss key components um, of sexual health history. And we're also going to think about different tips that we can use for facilitating a patient-focused discussions on sexual health, and also discuss promoting sexual health and wellness among sexual and gender diverse populations. And our learning objectives for today include defining barriers that may prevent providers and patients from discussing sexual health issues. Also identify key components of a comprehensive sexual health history using pleasure-based approaches, which may be something new for everyone here. And also discuss strategies for having conversations about sexual health and wellness to minimize sex-related stigma. So, how do providers talk about sexual health in primary care? Let's get back to the beginning of what is sexual health. Well, according to the World Health Association, our current working definition of sexual health is a state of physical, emotional, mental, and social well being in relation to sexuality. It's not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive, respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experience free of coercion and discrimination and violence. And for sexual health to be obtained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. And that's a very powerful statement in thinking about sexual health, because usually we're just thinking about how do we treat patients, how do we prevent diseases. But we see even in this definition, there's so much more that encompasses that. And the reason behind that is that with sexual health cannot be defined or understood or made operational without a broad consideration of sexuality, which underlines the important behaviors and outcomes related to sexual health. And lastly, we always, in thinking about patients and thinking about people that we provide services to, we need to think about their rights and how that's considered in relation to sexual health, and their rights when it comes to equality and non-discrimination, and the rights to be free from torture or cruel, inhumane, degrading treatment and punishment, and the rights to privacy. And all these different rights, it's essential for us in these clinical settings to make sure that we uphold these rights when we are engaging with patients. So, how do providers, now that's the main question we're getting to, how do the providers address sexual health in primary care? Well, one of the first things we look at is sexual history taking. And that usually comes about when a patient comes in with a complaint. And we also think about sexual histories as part of a routine care as not as common as those for specific complaints. So usually most of the time, we're not usually engaging patients in these conversations regarding their sexual history or their behavior until there's a problem that shows up. And many providers ask about general sexual activity, but not specifics like sexual partners and orientation, etc., and satisfaction and functioning. And the prevalence of sexual health concerns may be underestimated by physicians in these different encounters. So, a lot of times we have missed opportunities to engage people in quality sexual health care because we're just dealing with the one complaint or looking for complaints. And it's also difficult for us to know what a patient is experiencing, meaning that we only know what the patient tells us. So at some point, we have to take on a role as providers to engage patients in these questions and concerns without them being the ones who are initiating it. And why is this an issue? And I always like to say sex is still difficult to talk about. Many providers and research have shown that they're not receiving formal training in the medical schools and in other healthcare settings. Providers aren't sure what to ask or how far to push to get certain information. And then there's also issues around sexuality that many providers are not fully um, have full comprehension of regarding like sexual identity and gender identity. And so these misunderstandings and assumptions can really lead to mistrust and embarrassment. And for both the patient and the provider. And these certain emotions and feelings can accompany any sexual behavior. So when we look at certain populations, like among like HIV vulnerability among sexual and gender diverse individuals, having understanding the importance of recognizing this is essential because we know that HIV or the transmission of HIV as a social and psychological process is driven by social oppression. And so sexual risk behaviors are not the sole indicator for sexual risk for transgender and non-binary individuals experience it on multiple levels. And this is for not just transgender and non-binary individuals, but also for individuals who are categorized as being marginalized. And these are people of color. These are people who um, are identified as being gay or lesbian or bisexual. So this has happened across the board for any group that has been considered to be marginalized, and they face stigma and discrimination. And for specifically to transgender and non-binary individual, there's a lack of social and legal recognition of gender identity. There's also a lack of employment, housing, and educational opportunities, and barriers to gender affirmative health care. And as this diagram shows, is the HIV status neutral prevention and treatment cycle. And what we can see here is that across the board, whether you are living with HIV or you're not living with HIV, you can experience different forms of stigma that may influence your engagement in care. And so stigma and other social determinants of health can influence the HIV care continuum before even an HIV diagnosis is even made. And this diagram here shows how the track between stigma and and how it leads to poorer health outcomes. We see how stigma influences discrimination and harassment and abuse, which also can influence violence and poor health services, as well as being placed in at-risk situations or engaging in at-risk behaviors. And it also, we see how the bidirectional relationship to poverty, and all these factors are driven by stigma in our society, and they all lead to very poor health outcomes for people. So this graph shows the cyclical relationship between stigma and HIV, where it shows that people who experience stigma and discrimination are marginalized and become more vulnerable to HIV, as well as people living with HIV are more vulnerable to stigma and discrimination. What this shows us is that both internalized and anticipated HIV-related stigma are associated with decreased engagement in HIV-related care among sexual and gender diverse people. And so HIV stigma in itself is layered on top of other stigma, as we discussed before. And the intersectionality of HIV stigma with other stigma must be considered when developing and monitoring and evaluating programs to reduce it. So people who are stigmatized and who are perceived themselves to be stigmatized for having HIV may also experience stigma as a result of belonging to these stigmatized groups, such as racial and ethnic minority, transgender people, gay and bisexual people, transgender women, people with low income, sex workers, and drug users. And so this is why when we're addressing the sexual history, it's important for us to assess vulnerability. And what I mean by assessing vulnerability is that means that it's important for us, excuse me, to understand who our patients are and meet them there. And so here are we're going to discuss some tips for facilitating a patient-focused discussion on sexual health. And this is our way of trying to find our way around these pitfalls, so that we can encourage better communication between the patient and the providers. And just some background to understand, one of the valuable things to understand, and this is in relation to transgender individual people, is that we need to know that healthcare stigma can take many forms. Discriminatory attitudes on the part of healthcare providers may lead them to make judgments about a person's HIV status, behavior, sexual orientation, gender identity, and may result in the patient not being treated with dignity and respect. And this data shown from the national study of over 6,000 transgender individuals, 28% had experienced a harassment in medical settings, 19% were refused care, and 2% experienced violence in their doctor's office. And this prevalence of discrimination was even greater among people of color, as 17% of white people reported healthcare discrimination compared to 30% of Native Americans, 27% of multiracial individuals, 22% of Hispanics, and 19% of Black respondents. So again, it's important to understand that this is going to not just have an influence on the person's how important that the interactions in the healthcare settings has on the patient themselves. Excuse me, sorry. Sexual and gender diverse patients do experience multiple fears. One is being turned away and refused care and treated differently. Excuse me. Having to teach providers about transgender people. Um, it's really for patients. It's essential that their providers have some knowledge of who they are, their identity, and understanding. And so we shouldn't depend on the patients to tell us about these things that we should be encouraging ourselves to learn and grow more into. And they also have fears of being asked unnecessary questions, being ridiculed, and being assaulted by staff or other patients, and also being misgendered. So some of the common pitfalls that providers face is one, not talking about sex at all. And it's important for us to understand that sexual health is a big part of life. Excuse me. And it can have an effect, and it's affected by other aspects of health, including physical, mental, emotional, and social health. It's also essential to think about how we rely on risk categories. We put people in categories such as men who have sex with men, straight, gay identification doesn't equate behavior, nor does anybody want to be considered a risk based off of their identity. And you have to think about that when we're talking about sex and we're talking about health. And also, we need to think about that we do not have enough time or expertise. I think it's important and essential for providers, and you here are showing, and this audience are showing, that as providers, you are constantly learning. And it's important for providers to constantly stay abrupt with it, with terminology and what materials available to people. And we also need to think about that other provider thinking that other providers are addressing the issue. If you are engaging with your patient, it's essential that you talk to them about their health and not consider sexual health or reproductive health as something separate from their overall health outcomes. And so we need to lessen the number of missed opportunities for sexual health care. And so it's one of the ways we can do this is changing our approach. And our approach is changing from the traditional risk-based approach to looking more to a sex positive approach. And what we mean by sex positive is that we're instead of thinking that sex is risky or is stigmatizing or focus on just disease prevention alone, or it's ignoring developmental relational aspects of sexual health and not and making assumptions about people's life and their behaviors they give it into. We are focused on sex as being something that's a healthy aspect of their lives. It is normal. It's something that most and that's common among people. And we focus not just on disease prevention, but we also look at the importance of relationship building and sexual pleasure and lifespan changes. And we encourage the development of healthy relationship and sexuality. And we welcome diverse identities, orientations, and practices. And when we do this, it becomes patient centered instead of provider centered and focusing on risk. And so the ways that we can get around these pitfalls is one, we can ask about gender. Even in our own engagement, we can ask about their preferred gender pronouns. We can ask how have you ever, and don't press if you don't get those answers or thoughts. We could also ask about sexual behaviors, like what are the practices that you engage in? Who are your partners? What kind of protection are you using for STIs? Do you use toys or share toys? Those kind of things that people usually forget to talk about in these settings. And we also we can use open-ended questions, but try to be specific where at need. So, okay, one example is some of these questions may be a little strange or uncomfortable for you, but it's really important that we talk about this. And that's an important way a good way to kind of start engaging patients in this conversation. So they understand that it's not that you're trying to be nosy or you're trying to look down upon them. You really want to have this conversation because you want to foster better communication and support their sexual health goals. And so it's important for providers to be open and honest with their patients and to give their patient time and space and also ask about patients' concern or satisfaction with their sexual functioning. And so in these different settings, we try to avoid assumptions, meaning that you cannot always correctly guess someone's gender or sexual orientation based on how they look or sound. And it's also important to avoid assuming gender and sexual orientation with new patients. So instead of saying, "How may I help you, sir?" just say, "How may I help you?" Or instead of saying, "He is here for a support appointment," say, "The patient is here in the waiting room." And instead of saying, "Do you have a wife?" ask, "Are you in a relationship?" And so it's not just the provider I want to point out, but the whole clinical environment. So this starts at intake until they are complete their exam and complete their visit. So it's all staff and student, the providers and the staff should have this common knowledge on how to engage patients into care. And it's also important to think about the words and try to steer away from offensive language, especially for transgender individuals. There are many terms that are outdated and that are also offensive and discriminatory, and we should try to stay away from that. And it's also looking at unhelpful questions that you may ask. So thinking about asking a question like, "When did you decide to be a man or a woman?" Or, "You look so real, I never would have known," or, "Have you had what, or do you want the surgery?" Or, "What is your real name?" Instead of and saying something, "Are you're so attractive, why would you want to?" These kind of questions are offensive to someone who is transgender, and these should be removed from your thought process and when engaging with patients. So, um, just think about how being sensitive in your communication will affect your engagement and care with providers. And also think about the sensitive communication is other thing is saying things like, "I don't want to assume anything," will be helpful. If you prefer me to use other words to describe body parts, let me know. That is asking a patient like how they will want to refer to their different body parts. Um, or I will be asking you questions about your sexual behavior. I would discuss some sensitive topics. And most of all, I want you to feel comfortable. And by saying something like that, you let the patient know that if at any point that they don't feel comfortable, they can let you know and y'all could to move away from that topic and discuss it in a different way. And this way, again, it's a collaborative effort between the patient and the provider. And it's not that the provider is in charge, it's just that you are allowing the patient to be centered around the patient's needs. And so one way to that's this is a problem is thinking about the ambiguous language and stigmatizing language that we use constantly, not just in the healthcare settings, but also in research and in practice. So why language matter? Really is ambiguity. Using unsafe and risky to describe sex is scientifically in, price is incorrect. And this language conflates risk derived from individual behavior and risk derived from contextual factors. So the risks associated with condomless sex can be dramatically based on the context, meaning like looking at the sexual encounter, like who is the person having sex with, the person's socioeconomic position, and their role within a broader community. So in terms of sexual encounter, relevant contextual questions that affects risks include the following, like is it highly effective contraception being used? Is HIV prophylaxis pre-exposure prophylaxis being used? Has the HIV serial status been discussed between sexual partners? Is a partner living with HIV, and if so, is that person virally suppressed? Having this conversation changes the scope of looking, thinking that just because an individual is engaged in condomless sex, it means that they are engaged in riskier behavior. So, describing sex as unsafe and risky usually perpetuates stigma and thereby undermines our efforts in sexual health. And the use of stigmatizing language is associated with the transmission of bias, which is in turn associated with reduced healthcare access inequalities, as we saw from the previous slides. As healthcare professionals and clinicians, we may legitimately view condylus sex as unsafe and risky through the lens of HIV or STI prevention. But as we know, we have more knowledge about uh, we have more access to biomedical strategies. And we also know that it's not the only thing that places an individual at risk. And sexual health is not defined only by the absence of disease, but also by a holistic state of physical, emotional, mental, and social well being in relation to sexuality. Being By using risk-based language to describe sexual behavior, we perpetuate a long history of fear-based messages related to sexual health. Even in my own practice and HIV research, I try to refrain from using risk, the word risk, constantly or unsafe, because when I'm asking an individual question, if I'm asking them a question about the sexual behavior they engage in, why would I want them to think that I feel that their behaviors are going to be them having sex in general is risk? And we also think about how this ambiguous language or this risk-based language really contributes to HIV and STI stigma, which can hinder both the seeking of healthcare by those who need it and the provision of sexual health care by providers, and a disproportionate impact on the sexual health of people from racial and ethnic minority backgrounds and members of sexual and gender minority community and people of low socioeconomic status. We have seen it. We know that the fear-based messaging that we started out with doesn't work, and all it does is really hinder people from engaging in care and talking to their providers, talking to their partners, talking to their children and parents about their sexual health and behaviors. So instead of us using ambiguous or stigmatizing language, let's try to be more precise about the language that we're using with patients. So instead of saying, are you having unsafe sex? Ask them, are they having condylus receptive anal or vaginal sex? Are you engaging in risky sex behaviors? Ask them again, is this condomless receptive anal sex? Are you engaging in risky sex? Are you having and these are just examples of ways that people could do is looking at multiple anal and vaginal sex partners. Do you have a sex partner with someone with unknown HIV serial status without the use of PrEP? Are you engaged in condomless receptive anal sex with PrEP? Are you engaged with condomless receptive anal sex without PrEP? It is just sex between an HIV negative person and a person living with HIV unsuppressed with unsuppressed viral loads. You see how we get to what the situate around the person or ask certain questions so we can actually get good responses and address those responses as needed. And so it's important for us to hold space for inclusive language in sexual and reproductive health. And so that includes for us to think about what are the key components of our sexual health history, and that is accessing health and wellness. So, in your poll, you were asked, like, what are the five traditional P's? And so it starts out with partners. Who are your partners? Practices. What practices do you engage in? What have you had any past STDs? What are your pregnancy plan, and what do you do to protect yourself from STD or STI infections? And so, with facilitating routine history, it's important for us to consider the use of a form that can be filled out while the patient is in the waiting room to see the provider, and to ensure that the environment is confidentiality and acceptance is there. And so, the exam may be more appropriate to fill out some of these forms because you're talking about a lot of sensitive information. And conduct the interview before the patient changes into the gown for the exam, and be upfront about the onset of the interview. Like at our healthcare center, we encourage sexual health awareness for our patients, and part of that is listening to your concerns and asking you some important questions. So let them know that we're gonna talk about sex, we're gonna talk about the behaviors and things they're engaging in, and also remember that some patients may not have an interest in sex, and be respectful of that. And so it should be completed with all new patients. And it also should determine, yes, the risk and family planning concern, but also address sensitive issues such as sexual identity and gender identity. And it's important for us to acknowledge that sexual identity and gender identity does not always match sexual behavior. We shouldn't make assumptions about our patients' partners or and who they're having sex with. If this is their first visit, ask the patient how would they like to be addressed, like what is your preferred gender pronouns, and should it include questions about risk, violence, and coercion. And so, even with those five P's, it's important for us to move beyond that to address this. You see that the five P's don't really address gender and sexual identity, but research has shown that healthcare providers usually miss opportunity to engage people in sexual healthcare services. And so one of the ways that we can do that is create six P's, which is including gender inclusive sexual healthcare. And that includes looking at the partners and asking them questions like, what are the genders of your partners? Or pregnancy, how are you and your partner doing to prevent, what are you doing to prevent pregnancy? And how do you protect yourself against HIV and STIs? And past history of STI, what was it? Where was it? How was it treated? And practices, what kind of sex are you having? And which behaviors might expose you to your partner's fluid? And so, with that, we also need to add pride, problems, and pleasure. And with pride, that means we're recognizing that someone in gender identity, someone's sexual and gender identity from an intersectional perspective in historical context, cultural and structural. It uses names, chosen name, pronouns, and body parts in respect to their partner's decision. And the pronouns, and what pronouns, meaning what are their pronouns, and what words do you prefer for your body parts? are some example of questions. And thinking about sexual orientation and gender identity definition, it's important for us to recognize that sexual orientation and gender identity are not the same. And even the terminology for it varies. And so we also need to think about sexual attraction, gender expression, and all these different factors that encompasses an individual's sexuality. And think of and learn the terminology, and not make it again the patient's role or job for you to know the terminology, and ask them how to identify and be respectful of that. And so, with problems, we're addressing difficulties of when you have sex, such as pain, discomfort, vaginal dryness, a lack of arousal, lack of orgasm, a lack of erection, low and high levels of interest of having sex, and mismatched sex drive. So, one question that you can ask somebody is, what difficulties are you having while having sex? In your life or during sex? And are you concerned about your sex partner, your sex drive, or of your partners regarding like the high levels of interest in having sex and having mismatched sex drives? And so the best practices for attaining sexual health includes the introduction of the topic, the starting of the conversation and normalizing sexual health and the conversation around it, and also inviting the patient agenda, the patient-centered environment, and asking permission for with trauma-informed care, and assuring confidentiality in a safe environment, including verbal acknowledgement, and also being aware of your own implicit bias and assumptions such as towards race, gender, education level, income level, and sexual orientation identity. And that leads us to looking at pleasure. And I have a big focus on pleasure because I feel that what pleasure does is it helps us address all the other P's that we previously discussed. It allows us to be more inclusive, it be person centered, and it shows compassion while moving stigma in the conversation. And we constantly in our society, when we're talking about sex and especially sexual health, there's a pleasure deficit in sexual and reproductive health. We have this oversight given to the importance of pleasure and understanding sexual behavior and family planning. We've been very clinical about it. So here's some questions that we could ask that are focused using pleasure, but it will allow us to address all the other P's or different P's in the sexual history taking. So, pleasure. How is your sex life going? What concerns do you have about your sex life? That can lead to conversations regarding your past history of STIs, protection that you're using, pregnancy problems that you may be having, as well as practices. Are you currently involved in any sexual relationships? Is the sex you're having pleasurable? Why not? Why or why not? And are you and your partner on the same page about what's pleasurable? And do you and your partner talk openly about desires and boundaries? And are you yeah, sorry, excuse me. And are you able to advocate for sexual pleasure in your relationships? Asking these questions, which are very like open-ended, but can lead to discussions about your pride, about practices, about protection, about partners, and problems or pregnancy plans. And so, as guidelines, it's important for healthcare providers to familiarize yourself with commonly used terms and diversity of identities. Listen to how people describe their own identities, partners, and bodies, and use the same terms. And refer to patients by their preferred names and pronouns, and refer to body parts by their preferred names. And if you're not sure what term to use, ask your patient what they prefer. Realize that many have negative experiences in the past and may perceive slights, even when not intended, and avoid asking questions out of curiosity. Ask what you need to know and don't forget the basics. And our final thoughts is that sexuality and sexual health are important parts of healthy living and wellness for most people. It can be a tough thing to talk about in a clinical setting and everywhere, But it's essential that we provide comfort and rapport and trust between the provider and the patient to make sure that we provide high quality health care that includes sexual health and wellness. And we should always be ready to talk, but also we should be ready to listen. That's a tendency that we have that in our roles that we are the expert. But you have to realize that your patient is an expert on what they're experiencing in their life and on their body. And so we have to be able to listen to them and respond to that. So if you don't know something, ask a colleague, listen to your patient, and they can be great educators. And there's plenty of materials and resources available that you can find from different organizations at this time. And if you have any questions, please feel free to ask. Thank you.
Thank you very much, Dr. Bond, Dr. Keisha Bond, for what I think it's a really very comprehensive, enlightening, I would say very practical presentation as well. Thank you for sharing all of those tips that we as healthcare workers can use to be able to take a better sexual health history. Really important. I know your penultimate slide spoke about, this is often it is very important for us to take a really good sexual health issue, but it's sometimes very difficult for us to be able to speak about sexual health with our patients. So thank you really for sharing some great tips on how to take a good sexual health history and how to speak with patients about sexual health. I particularly like your slides on the relationships or the interaction with HIV vulnerability and sexual health and gender diversity. So really, again, I do appreciate you spending some time talking with us about stigma and discrimination as well, and its cyclical relationship with HIV and vulnerability, and also touching on some of the multiple layers of HIV stigma and discrimination. Um, for going in depth, looking at the pitfalls of healthcare workers and talking about sexual health. And again, for sharing some really good tips on how we can do this better. Particularly, I like your slides on how can we shift our approach from a risk-based approach to a more sex-positive approach. I thought that was really very interesting. And again, very practical, but also being able to, as healthcare providers, avoid some of the pitfalls, avoid making assumptions about patients, being able to have really mindful and sensitive communication with our patients, for example, being very direct and precise in the language that we use about sexual health, and also, I think it was really interesting you spending some time adding on AP to the CDC 5P, looking at problem, pride, and pleasure as we sit with patients and we talk about sexual health and being able to get a comprehensive sexual health history. So, again, thank you for a really comprehensive presentation. And I can see that we do have some questions that have started coming up. Let me see what those are. For our attendees, please go ahead and start submitting your questions, and we will take them now. Dr. Kishaban will spend some time to reply to you, to your questions. One.
Definitely. Thank you for inviting me. I think this is great. And I'm pretty sure that some of this information has been a repeat for the attendees, but hopefully everyone found something to be useful.
Yeah. So I don't have any question at this point. We're just getting some comments saying thanks to you for this session. So again, thank you, Dr. Bond. What I'll do in the meanwhile, as we await questions from attendees, I will put up the results of the poll. I'll put up the results of the poll, and maybe you can just take us through,
Sure.
um, Dr. Bond. So I have the result of the first poll that is up. Can you see that?
I cannot see it yet. Maybe, let me- okay, now I can see it. Thank you.
Okay, great. Thank you.
Okay, so we have here implicit bias is or stereotypes. 35% reported that they believe it's stereotypes or bias against a group of people that maybe it got cut off. Um, and is not inherent. Our bias derived from conscious desires, and it's not real. So these are the responses that we receive regarding implicit bias. And one of the things about implicit bias is that it's one of the aspect of our interactions with each other that we are constantly thinking that, oh, um, this is something that I don't have because I don't have these strong negative feelings. But implicit bias is basically what it is that we don't mean to, but it consciously, based off our own experiences and how we, our own, like, so how we socialize, we do ourselves create our own biases and stuff. And so I don't know if the poll is able to show the correct answer so everyone can see and highlight it, the full answer. Is that an option with the poll or?
Are you seeing the poll results, Dr. Barr?
I see the poll, but it gets cut off, so I can't see the full responses for this one.
Okay.
Yeah,
All right. So let me see if I can tell you. So we had 35% of persons um, replying to, I see. Yeah. All right. Let me go to the second poll. Can you see that?
I can see that. And healthcare providers should be aware of the factors that cause individuals to be unique. And I'm happy that the majority of people said true to this. It is important for healthcare providers to recognize that all patients are not the same. They're different, and to treat the patient based off of how they come in, meaning that they do have unique factors, and we need to be responsive to those factors and understanding. And that helps us to kind of minimize the stigma that they may experience in the healthcare setting.
Great. Let me turn over to the final poll. Okay, there you go. Can you see that?
Yes, I can see it. And so everyone here, the majority of the participants here, had great knowledge of the CDC's 5 Ps. They responded with pregnancy, past STIs, protection, partners, and practices. And this has been common and been used for many years, for decades. But it's important now that with more knowledge that we expanded and we include factors such as pronouns and thinking about problems as well as pleasure and thinking about pride, people's sexual orientation and gender identity, how not just if sex is, for disease prevention, but how is it affecting their entire lives beyond that? Like, are they enjoying sex? What are these different factors? And because that allows providers and um, to figure out ways to support the sexual health of their patients. And sometimes when they just come in, a patient comes in with just a complaint, we don't get the full story in that way. So it's important for us to, again, to continue with the traditional um, 5 Ps, but also expand it so that we can be supportive and understand different factors that may hinder them into engaging in care. So if you have a patient who is in a problematic relationship and experiencing intimate partner violence, they're not going to be able to engage in sexual health practices that you may recommend to a common patient, someone who's not doing that. And we know that these are different factors. Being told that they not allowed to use condoms, or even being told that they can't take medications such as PrEP. So all of these factors are important. I'm not saying that clinicians are the problem solvers, but you can be a change agent, and you can help with navigating these different services, meaning that if you do have a patient who is presenting with some type of abuse or problem, you can point them and connect them with the services that they need. And so that in a way to provide them with more support that will support not just their overall well-being, but their sexual health in itself. So I hope that everyone would consider looking at the plus aspect of the sexual history taking, and understand how that in itself, and think about different ways that you can incorporate that with your patients now.
All right. Thank you, Dr. Bond. I think it's time for me to do a really quick wrap up and close this session. So, on behalf of the partnership, the PANCAP partnership and Pan American Health Organization, and all of our participants today, again, thanks to you, Dr. Bond, for sharing your hour with us this morning, and for sharing your knowledge, your experience, and for doing this presentation. I want to thank all of the participants for joining us also this morning. Please do join us for our next webinar that is scheduled for Thursday, the 20th of September, same time at 11 a.m., where Dr. Omar Sued, who is the PAHO WHO advisor on HIV treatment, will present to us on critical interventions to scale up care and treatment, HIV care and treatment, and early linkage to care, with a focus on the use of dolutegravir as the preferred first-line therapy, also looking at same-day staging, same-day treatment of HIV, as well as same-day identification and prophylaxis and treatment of opportunistic infections in people living with HIV. So very interesting session on Thursday, the 20th of September, same time at 11 a.m. This is one final kind reminder to you that you will receive a post-webinar survey. Please do provide us with your candid feedback. Again, thanks everyone for staying with us for this session, and do have a good rest of the day. Thank you very much.